Hi.
Hey Claudia,
Hi, how's it
how
going?
how are you?
Oh, pretty good.
Good. Exhausted?
Yeah, I'm tired. I've had the last couple days. Well, yesterday we like drove home we left at 6 so we could put the kids in school. But
Oh my goodness.
yeah, it's
How
okay.
how was your first session up there? Busy, not busy, okay, not okay?
It was pretty good. I definitely had some pathology. My first day I had a STEMI and a
Yeah.
brain bleed, and
Oh man.
so it was pretty, yeah. I mean,
It's
it's similar to Taos, like more resources, but people that maybe, I don't know, just different. People
it's
there don't
cowboy
take care of
living.
themselves.
Yeah.
Yeah.
Yeah, it's hard living up there, I think. A lot of people
Yeah.
who yeah, live a rough life, right?
Yeah. It was like, I think it's a kind of a combination of Taos and Columbus. Like the patient population reminded me of Columbus a little bit. I had like a
Did
31
they?
year old that, oh yeah, I had a 31-year-old that like had already lost his leg and his eyes
Oh
and
my
his hand from
gosh.
diabetes. I'm like, oh yeah, this is like Columbus.
This is just under-resourced individuals who yeah,
Just
um
don't know any. Yeah. I mean,
don't know
they're,
any better.
yeah.
Yeah.
And
How's your
then like
family?
don't want to either. There's, I mean, you got to put
Yeah.
some onus on them.
Yeah,
They're
of
like,
course. There are cultural reasons that for
uh,
whatever it is, they just they don't get it.
yeah. How are you
So
doing? How's your shift
I'm
today?
I'm good. My shift was busy today. The hospital is, as I'm sure you know, since you have probably tried to been transferring patients down to VU, is just completely chock full. So,
Uh-huh.
that doesn't keep patients from coming through the front doors, but
Yeah.
it's challenging. So this is my second of five shifts I've got in a row, which is just
Oh
exhausting.
man.
Yeah. So I
Yeah.
mean, but no different than what you just did up at Rock Springs. It's a
Well,
lot.
actually, way shorter.
Yeah.
That's
I
okay.
it's just it's hard.
No,
It's hard.
yeah, the 12 hours. Yeah, it's
Those are
hard,
terrible.
but 12
Yeah,
hour shifts.
those
That's what I did, but they get
they suck.
exhausting. You're like,
They're exhausting. One or two is exhausting. So four in a row is
yeah,
really quite a bit.
but
How
it's
did your
fine. Yeah, the other docs were great. They're really nice. So
Who'd you work
it's a
with?
young group. I worked with
It is
um I worked with Wes,
great.
but and I
Fettuccine?
worked with, yep, and I worked
Great.
with Alicia,
Great.
and I
So
worked with, um oh my gosh, I can't remember her name. She just signed on there. She was really good. She's, oh gosh, it's gonna make me mad that I
hmm,
can't remember her name. And then yeah, it was good. It's a pretty young group,
it is. They're fantastic physicians up there, I
but
think.
most of them are, I'm a little nervous. Like a lot of them are leaving.
Did Wes tell you that he's
Yeah.
leaving? Yeah. And I
Yeah.
think
And then Alicia's
yeah,
going down to like she's taking less and less shifts.
is she?
Yeah.
I'm looking at some of the names in there I don't recognize, like a Wittison.
Uh-huh.
Looks like you worked with maybe David Crockett too.
Yeah, I worked with Crockett.
Spectacular.
Yeah,
Yeah.
he's nice.
Yeah. And James Fearbaugh, was he there while you
I
were? Maybe
No.
not. Maybe you took sign up from
Mm-mm.
him or not. Hmm. Um,
No.
yeah, I think people get tired of the travel, Claudia, is my
Yeah.
impression, and I think
Have
we
you
could talk
worked
about
there? Have you worked there at all?
so they got that contract a year after I was a fellow.
Okay.
And I
I
think
think
one of
the yeah.
yeah, I think one of the biggest missteps that they had was not credentialing all of the faculty and asking all the faculty to go. Because
Yeah.
I certainly would have liked to, but as you know, having gone through the credentialing process, they only meet three times a year to credential physicians. So I think
Yeah.
when there is a problem or a physician steps out or can't
Hmm.
work, like Justine McNeil because of her injuries, suddenly they're really left shouldering the entire burden, which is overwhelming. So
Yeah. The the thing there is like they, yeah, I think it just, I don't know. I think part of it is there's some core nurses that are okay.
mhm.
And I mean, this is my perspective, like having a little more experience than some of the fellows. Like the
Yeah,
core nurses are okay, but then there's some travelers that are not very good. And then even like the nurses from there can be tough.
yeah,
And I
Yeah, I
think that
think
that's like Wes was like, he was kind of telling me, he's like, if it was worth it and the nurses were good and it like functioned and they did,
yeah.
I put an order in and it got done, he probably would have stayed
I
or done
think
the
yeah.
travel. And
I
yeah,
I think
yeah,
yeah, I think it's hard, and you as a parent,
yeah,
like you're now understanding how difficult it is, one, to bring your family or to leave your family,
yeah,
like Wes is, having to do with his kiddo. So
yeah, for sure.
I think there's just some systemic issues that probably need to be
Yeah.
addressed both by the leadership of the hospital there and our leadership. So
Yeah, it's okay. I don't mind. I just don't want. I hope
oh, I
it
know.
doesn't turn into like me going there every other month because I'm gonna be really
No,
stressed. That's the case.
it better not, because that's not okay. And
Yeah,
I as your advocate will do my utmost to prevent that from happening. So I don't think that's
yeah,
fair. So,
yeah.
and if it comes down to it, then we'll talk about solutions.
Anyways, hi guys. Hi everybody from Vietnam. Love them.
Xin chào, friends. How are you? Hi Dai. Hi Huang. Hi Hui.
Hi, Matt. Hi, everyone.
How are you?
Morning, everyone.
Hui.
Hi. Oh, let's see. Do you know if the UMC group is coming? It usually says UMC.
Yeah, Dr. Hui is one of the UMC docs, but
Oh,
is
okay,
Dr.
that's
Hao?
right.
Yeah. Is Dr. Hao going to be here, Hui?
Dr. How is busy today because
Okay.
it's
Oh,
International Day.
That's
okay.
okay.
That's great. This is probably going to be it then. That's just so we can get started. So
Yes.
just to sum up this, so this is the last lecture for this block, the shock block. And anaphylactic shock, it should be like the most straightforward for treatment, the most under recognized. And so it's a little shorter. I did put some questions in. If you guys looked ahead at the questions, I put some questions just to kind of wrap up the entire block that I've been talking about. And so when this is done, if you guys have any questions, or if you want to talk about the other subjects, we can, because this one is on the shorter side. That being said, the thing I like about anaphylactic shock is this is a area of medicine where we can like actually make a big difference. We're not giving somebody some long-term complicated ICU stay, and we don't have questions about what their long-term is going to be. If we treat this right, we can send people out the door. And so this is one where it's good to know because we actually make a difference. And it's sometimes hard to feel like you're making a difference in emergency medicine, but this is something where if you recognize it, you treat it, you make a huge difference, and you can save somebody's life pretty quickly. That being said, so anaphylaxis, so just overview, allergic reaction is occurring when a body has a hypersensitivity to a food, protein, or allergen. And when we're talking about anaphylaxis, we're talking about a severe, immediate hypersensitivity reaction that can lead to cardiopulmonary collapse or cardiac arrest. So how these people are going to present, so it's typical to your other shock. It's the most important thing, and like really the biggest thing for this entire lecture, and anytime we talk about anaphylaxis, is recognizing it, knowing when to treat it and when it's anaphylaxis and not just your typical allergic reaction. So you're going to think about anaphylaxis and anaphylactic shock if somebody has acute mucocutaneous, so that's skin symptoms or mouth, like a rash, with flushing, pruritus, or so itchiness, angioedema, tongue swelling, plus one of the following, either respiratory symptoms like a wheezing, a stridor, they're hypoxic, or hypotension, or end organ damage. So they don't have to have all three of those. They only have to have a rash and then one of those. Or you can qualify it if somebody has two symptoms of the following list that occur really sequentially to getting exposure to an allergen. So a mucocutaneous, so that's in the mouth, breathing or respiratory symptoms, hypotension or end organ hypoperfusion. So if they're showing signs of renal failure, if they have altered mental status, if they have abnormal liver enzymes, Hopefully you're not waiting to get blood on these patients, but if they show signs of that, or if they have gastrointestinal symptoms, that typically presents as like nausea and vomiting. The other time when you would consider anaphylaxis is if somebody has hypotension and you know that it's allergic reaction. This would be something like pretty hard to diagnose if they didn't have a rash or any other symptoms, but you would just be hyper aware if somebody knew they had an allergy and they were hypotensive. As far as the presentation on exam, so I kind of put these in there because I thought this was interesting to think about. So 90% of patients with an allergic reaction are going to have a rash. And that's what I found in some data. If you like look down at the bottom, it does kind of tell you though that up to 20%, so it's somewhere between 10 and 20% of patients with anaphylaxis don't ever have any type of rash. So just because somebody doesn't have that typical allergic reaction rash, don't discount it to being anaphylactic. 60 to 70% of people, and this is with anaphylaxis, not just allergic reactions, will have some sort of respiratory symptom, so dyspnea, cough, and then that includes kind of oral stuff, so the stridor or the voice change. 40 to 55% will have gastrointestinal, either pain, vomiting, nausea. 40 to 50% will have chest pain, palpitations, arrhythmias, dizziness, syncope, low blood pressure, shock, and cardiac arrest. And very few will actually get the neurological symptoms from allergic reaction. So when you're seeing them at the bedside, aside from these kind of things that we're talking about, the one thing on your physical exam you can see is, remember, it's sort of like septic shock, and they have this massive vasodilation. So it's the mechanism of why is a little bit different, but you're getting this, all your vessels are dilating, so you're not perfusing very well. So people are going to have poor capillary refill. You're not going to have that bounding pulse. And because of that vasodilation, your heart rate's going to go up. So a lot of these people are going to be tachycardics with their hypotension. And so it presents similar to septic shock without the fever, as far as just looking at a patient in front of you. Most of the time, you're going to get a good history, like this was an allergic reaction. I had some sort of exposure. The other thing to remember is with allergic reactions, just think about the fact that when somebody comes with the first time allergic reaction, if it's on the more severe side, but not true anaphylaxis, I like to tell these patients, and it's good to let them know and make them aware that sometimes a second reaction can be worse. And sometimes people's after exposures, they can have their subsequent reactions can be worse and worse and worse. So if somebody comes in there on the edge of being anaphylactic, then it's really important to make them aware that they could become anaphylactic in the future, and know and tell them the signs and things to watch for. So for the shock, somebody comes in, they're in anaphylactic shock, they meet kind of that criteria, or at least even if, your clinical judgment's telling them in shock. The treatment is pretty straightforward. You obviously want to remove any insulting agent. So if somebody has, it's rare that anaphylaxis is going to be caused by something that's topical, like a lotion or a laundry detergent. But if it was, you want to take those clothes off. If somebody has exposure to peanuts or dust, like take their clothes off. Make sure that there's no remaining allergen left around that could worsen the reaction, even if you're treating them. And the biggest thing is epinephrine. You have to give them epinephrine. So the dosing for epinephrine, you're going to start at 0.01 mg per kg IM, and that's the 1 to 1,000 of epinephrine. So you can do a maximum dose of 0.5 milligrams in adults, and oftentimes you're just going to give the 0.5 milligrams. It maxes out pretty easily in adults, like an average size adult is at the maximum. And then in kids, and again, it's pretty easy. It's usually 0.3 mg per kg. That's the immediate dose, or the 0.01 mg per kg. But their maximum dose is 0.3. So you can repeat this every 5 to 15 minutes for up to 3 doses. So I wouldn't wait a whole lot longer than 5 minutes to redose, because usually the effect of epinephrine is pretty rapid, and you're going to be in there constantly reassessing them. And 5 minutes is going to seem like a long time if they're hypotensive and really crumping, but 5 to 15 minutes, you can do it up to 3 doses. If you're getting to that third dose, oh, go ahead.
Oh, no, go ahead, Claudia. Sorry, I was just going to interject, but keep talking.
No, go for it. No, please do.
I'm sorry to interrupt. I think one of the things that I just want to emphasize that Dr. Bouvier is talking about is the underutilization of epinephrine. I think all too often we're too afraid to use epinephrine for whatever reason, at least in the emergency department and in the United States. And a number of papers that I'll share with you, I'll put in the chat box, have demonstrated the underutilization of epinephrine, leading to significant morbidity and mortality in patients in Western emergency departments. And I'm uncertain, I haven't seen enough anaphylaxis in Vietnam, but at least in America, we don't use it often enough. So I really agree with Dr. Claudia. It's very, very important to continue to use this. It's not dangerous. It's not dangerous. It's not dangerous. Use epinephrine. Sorry to interrupt, Claudia.
No, I mean, I agree. That's kind of the main, that's why it's highlighted. It's I try to repeat it multiple times. And I don't know what it is about the culture, why people are afraid even to give that first dose. We do a lot of adjunct therapies that really have not been shown to do anything. And we're throwing these all at patients without just giving them the treatment. And sometimes you get pressure from staff. And sometimes it's hard because when you do administer epinephrine, you're stuck watching them. So I think you try to convince yourself that you don't need to give it, so you don't have to watch them as long, but really you have to give it. And yeah, I think even going back to that slide that was talking about, having 2 of those symptoms, and we all know there's a lot of patients that we've seen that have like vomiting, and they have a rash, and maybe they have a headache, and you convince yourself away from it when really we should be using epinephrine on these patients. And then if you're getting to kind of jumping back, and if you're getting to your 3rd dose of epinephrine, it's been 15 minutes, you're doing 3, this is the time to put them on an epinephrine drip. And again, this is something that people shy away from, but we don't have to think of this as quite the same as like when somebody's intubated and it's their pressor. You can do a really low dose of epinephrine IV, start at a low dose, and then they're getting it continuously. So it's okay in these patients. These are usually your people crumping if they've been this unresponsive to epinephrine, but that's where I would go. So I would do 3 doses, either maybe wait 45 minutes at that point, and then you would start the epinephrine drip. And that not just on your intubated patients, these are to treat the hypotension. So specifically to treat hypotension, you would do an epinephrine drip. There are adjunct therapies like I talk about. So, you can give steroids, so methylprednisone or hydrocortisone. There's been a lot of studies and they really have not been shown to do much. I will use these in people that have airway involvement, just because I do think that it helps a little bit, or oral involvement. So if somebody has swelling in their mouth, their tongue, difficulty breathing, I always do steroids on them. I will also always do steroids if somebody has a diffuse rash, because it can help them symptomatically. It can take away some of that itchiness. So most of the time, if I'm giving epinephrine, I end up giving steroids. But if you're not going to give epinephrine, there's not a huge use to using the steroids. So it's not like you can replace it for the epinephrine. The antihistamines, you can act on both. And this is really just to help a patient's symptoms. Also can help on the cellular level to help kind of suppress a recurrent reaction, would be diphenhydramine or famotidine, which is Benadryl or Pepsid. I'm not sure how you guys use, what names you use, but those are them. And then if somebody's wheezing really bad, they have a history of asthma in addition to this allergic reaction, which a lot of people, somebody that they have those receptors, they're more susceptible. If somebody's wheezing a lot, you can give them a bronchodilator, so an albuterol inhaler, and they can get this at the same time. And it's also a way to administer additional oxygen. So that's a nice option. And then IV fluids in these patients, they are, like we talked about, they're vasodilated. So their fluid is not in their vessels very well. So you can give them fluids and that can help. Something else to remember, if there's an adult and they're on a beta blocker and they're still hypotensive despite epinephrine, you can try glucagon, and you do 1 to 5 milligrams IV, and then you can put them on an infusion if you need to. And that's to counter the effects of the beta blocker on the blood vessels. So not necessarily the heart, but the blood vessels. And it helps them be able to vasoconstrict, and it will raise their blood pressure up. If you're at a facility that has it and somebody's just really tanking, you can also use ECMO, but hopefully we're treating them long before they get to that. So if you get to the point where these people need to be intubated, this is a patient I would for sure, depending on your comfort level, I would get anesthesia if you have it. If you don't and you're managing the airway, think about doing this as an awake intubation. So how this would happen is you would give some ketamine, so no paralytic, just the ketamine. And you could do a dose like you're doing a sedation. So 1 milligram per kilogram of ketamine. You get everything set up and you use the fiber optic scope. So you go in slowly and then look and see what you have. That way, if you get in there and they're breathing a little bit on their own and you get in there and there's just so much oral swelling, you have time to like really plan it out and make different considerations. You can change your tube size. You're not taking away their ability to breathe if they're breathing on their own at least a little bit. So this just is a little safer way to go ahead with an intubation. Obviously, if they're crumping and you have to do it, you can just do a regular intubation, but I would always prepare on these patients if I was going to intubate them for doing a crike. So having, your scalpel ready and your bougie ready. And just having everything ready, or having a surgeon at bedside if you have that ability. But these are people, if they're getting to the point where they need intubated, you call in the cavalry, because you could get in there and you could have a really limited view. If there's swelling of the tongue, you could not even be able to see, your epiglottis. And so that's why you would do that. That being said, too, for the awake intubations, that is one nice part. If you do an awake intubation, somebody has a lot of swelling on their tongue, you can actually have them sitting up to do the intubation. So if you just give ketamine, you can sit them up as opposed to lying them down. And that allows the gravity will help you with the tongue. So you're not fighting the tongue as much. So you sit them up in a prone position a little bit. And with awake intubations, you can also do it intranasally. So if you really think their tongue is so swollen, you can do an intranasal awake intubation. Are there any questions about the airway? Because it's kind of a lot, and you can write it in the chat, or if you guys want to talk about it anymore. I think we can always talk about it later. You guys can send me questions, but there's some videos I know out there. So it's definitely something worth looking at and having just in the back of your mind as an option if you needed it. So your disposition. So for us, that is basically, what are you going to do with this patient? So if you're going to admit a patient for anaphylaxis, it's been in anaphylactic shock, they're going to the ICU. I cannot imagine a situation where I'm intubating a patient, or not intubating, where I'm treating a patient for shock. I'm so worried about him, I'm keeping him in the hospital and not just putting them in the ICU, because you're worried that they're going to have respiratory issues or blood pressure issues. So for me, that's kind of where it goes. If you're going to keep them in the emergency department, which you can do with a lot of these patients, and then discharge them from the emergency department, the recommendation is to watch them for 3 to 6 hours for rebound symptoms. There's not a time, there's no clear time, there's no clear, as much as I've looked for it, I wish I had something that just said, this is exactly how long to keep them, but there's not. I will typically, depending on the severity of the reaction, I'd say I probably wait 4 hours if I'm giving epinephrine. If they had a really mild initial reaction, you can do 3 hours, or if they're really normal, you could do 3 hours and give them an EpiPen to go home with and instruct them how to use it. So they know how to use it if they have symptoms. And in these patients, you can discharge them with additional Benadryl or the antihistamines and then steroids. And that's kind of just personal preference, because really it doesn't show too much. And then make sure also that you're giving them information and telling them to really try to avoid their allergen and not end up back in the ER for it, because some people just don't think about that or process that. And then you can send them to allergists if that is readily available, but it's often not. So they have to just kind of work their way through and try to figure out what caused the reaction and go from there. So I got the questions now. And yeah, are there any questions before we move on to the questions?
Claudia, I'll just make a quick comment on biphasic reactions.
Yes.
A lot of recent literature suggests that it doesn't happen very often. But our practice in United States emergency departments still is to give the steroid, like you said. And then my personal practice is, if I've given epinephrine, to at least watch for the 3 to 6 hours, like you mentioned. I had never personally seen a biphasic response or biphasic anaphylaxis up until 2 weeks ago. And the patient was incredibly sick and probably would not have survived if I had sent them home. This was somebody that we had to redose with epinephrine, put on an epinephrine drip, and admit to the ICU. And so I don't know if any other providers have had any experience with it, but it was enough to convince me that despite a Cochrane review saying steroids don't matter, this was a patient we had not given steroids to, and a Cochrane review saying we don't really need to watch patients this long. My personal practice will continue to be to observe patients. I give epinephrine in the emergency department for at least 4 hours. And then, like Dr. Claudia said, make certain they go home with epinephrine and the knowledge on how to use it. So yeah, great lecture, Claudia.
In my experience, when we use the patient with the dyspnea with the anaphylactic shocks, we use adrenaline for nebulize. We use adrenaline for nebulize in the patient with the wheezing and dyspnea.
Yeah, absolutely.
I agree. We also nebulize adrenaline. We here.
Okay, and I see the patient come better after nebulize adrenaline. So I cannot find the evidence for use adrenaline for nebulize, evidence based. You know.
You've got a paper you will have to write. Now you have to write a paper with Dr. Claudia.
No.
Yeah. It makes perfect sense, because if you think about it, you're using it if somebody has stridor for, different reasons. They have a narrowing of the airway. You're going to give nebulized epinephrine for that exact reason. And it's the same thing that's happening with anaphylaxis in those cases. So I think it's a great way to give it. And, kind of, we talked about, you can't give enough epinephrine. So you're giving them epinephrine in multiple ways. So I think that's a really good point. I like that. I don't think I've never done that, and I should. It makes great sense.
The position the patient when I show the patient and I transfer to the ICU department, because we have no EpiPen. We have the EpiPen for the patient discharge.
Oh yeah! Wow.
And another thing is about different diagnosis. So the patient come to the emergency department. We diagnose different diagnosis about the angioedema. Thanks for remind me about the angioedema, and we treat use the FFB for angioedema.
Yeah, definitely. And sometimes it's, it's hard to say with some of those, like an angioedema that would be from a medication. Is this an allergic reaction anaphylaxis or angioedema? And sometimes it's unclear at that initial presentation also. So you can treat it like it's an anaphylactic or allergic reaction.
Yeah, thank you.
Yeah. Yeah. So questions. The first one, 8-year-old male with past medical history of peanut allergy presents after eating a cookie with unknown ingredients. Prior to arrival in the emergency department, his mom noticed a diffuse urticarial rash. He began to complain of oral swelling and difficulty breathing. She administered his EpiPen approximately 15 minutes prior. Upon your exam, the patient is complaining of persistent difficulty breathing and oral swelling. What medication should you administer immediately? Great. I think everybody got the answer here. D. So driving home that point that, even if they've gotten epinephrine, you want to make sure that they get additional epinephrine. And, I really would hone this in on these ones, depending on the patient too. Sometimes they don't administer it right, or, it could be an expired EpiPen. There's a lot of reasons why, yes, when they give it at home, they usually do it right, and you're still going to give epinephrine, but just make sure. Oh, yes. Good point, Matt. That was just, but yeah, so definitely epinephrine on this one. Okay. Next question. This kind of talks about what Matt was talking about a little bit, but 16-year-old previously healthy male presents for evaluation of difficulty breathing, throat swelling, nausea, and vomiting after eating a birthday cake at a birthday party. He is successfully treated with epinephrine and his vital signs are stable. Which of the following is true regarding biphasic anaphylactic reactions? So A, they're more common when the initial treatment is suboptimal. B, they tend to occur in the first 4 to 6 hours after resolution of symptoms. C, they tend to be more severe than the initial episode. Or D, they require treatment with high doses. I'm going to give you a hint, and that is not what we just exactly talked about. Yeah, Matt says A, B, and C, which, yes, because I know we just had the conversation that we do wait the 4 to 6 hours, and that's true. These are all a little bit true, I guess. What is the most true? I'm just going to tell you is A, actually, that they're more common if the initial treatment is suboptimal. So that's if you're underdosing epinephrine or they don't get enough epinephrine right off the bat. So really what this is saying is if you don't fully treat your patient, they are probably still going to have symptoms. If you give somebody a single dose of epinephrine, you reevaluate them and they are still symptomatic. So they still have some nausea or vomiting. They still feel a little oral swelling or difficulty breathing. That is not a full treatment. You need to treat them again. You need to give them additional epinephrine. So those patients that are still feeling symptomatic after their first treatment of epinephrine, they need another dose. Otherwise, they're going to have worsening symptoms. So that's kind of what that's saying. Yes, they do also occur in the first 4 to 6 hours. And this was one I wrote most of the questions this week, but this is one I stole out of, our boards. And that's why some of these questions are tough because it's hard to say exactly. And there's multiple right answers, but just remember, you got to fully treat your patients. You want to give them epinephrine until they have very minimal to no symptoms, because that means that you're completely treating their allergic reaction. And this is our last anaphylaxis question. 36-year-old female with multiple food allergies presents with concern for reaction to a dish she started eating approximately 45 minutes prior to arrival in the emergency department. She complains of a diffuse rash, oral swelling, nausea, and difficulty breathing. Vital signs are as follows: blood pressure of 85/60, heart rate of 118, respiratory rate of 28, pulse ox is 88% on room air. She has a diffuse rash, mild oral swelling, and wheezing. You administer 3 rounds of IM epinephrine over 15 minutes with mild improvement in her symptoms. Her vital signs are as follows: she still has a blood pressure of only 88/65. Her heart rate is 120. Pulse ox 93% on 2 liters. No more wheezing, and breathing is less labored. But what is your next step in management? I think I got everybody. Yeah, very good. Everybody got it. So this patient is still hypotensive despite 3 rounds of epi. This is the patient you're going to put on an epinephrine drip. That blood pressure is still just really soft for somebody in shock. And you would expect, with having gotten epinephrine, that it would be quite a bit higher if she was getting adequate treatment for her allergic reaction. So that's great. So that is, I got a few more questions in here today, just to kind of, just a refresher. I pulled questions from our other lectures just to reiterate the points, and we've done a lot of critical care stuff. So just going to review them and make sure that we all kind of got it, all the topics. So this one, an 80-year-old woman presents from a nursing facility with a fever and confusion. On arrival, she's alert, able to follow commands, but is oriented only to self. She has a temperature of 39 degrees Celsius. Her heart rate is 130 beats per minute. Blood pressure 70/40. Respiratory rate of 24 with an oxygen saturation of 98%. Her exam is notable for tachycardia, clear lungs, and a 4-second capillary refill. She started on broad spectrum antibiotics. She got 2 liters of fluids. Her repeat vitals are a temperature of 38.7, heart rate of 110, and a blood pressure of 80/50, respiratory rate of 20, and she's still 98%. Her physical exam is unchanged. Which of the following is the most appropriate next step in this patient's care? Good job. Everybody got it. So this patient is ready for norepinephrine, so ready for vasopressor. She's still hypotensive despite basically a 30 cc's per kilogram bolus. She got all her fluid, needs to be started on a pressor. And on septic shock patients, which this patient is, our pressor of choice is the norepinephrine. It's going to be really good for their vasoconstriction and help get things going. So great job. And oh no, well, they peaked. Okay, next question. So 63-year-old female with history of congestive heart failure presents for evaluation of shortness of breath. Her heart rate is 115, blood pressure of 190/100, respiratory rate of 28. She's 82% on room air. She has diffuse rales. Which of the following is true? Patients in CHF present with severe hypertension, have a higher mortality rate than patients that are hypotensive. Lasix or furosemide is the initial treatment of choice. The patient should undergo rapid sequence intubation and mechanical ventilation. An intravenous nitrate infusion should be started, or non-invasive ventilation is contraindicated in the setting of severe hypertension. Good. Everybody got that one too. I think that this wasn't quite the shock, but it's really just an important thing to remember: the cardiogenic and heart failure IV nitrate infusion. So just kind of putting this one in there to remind us of the heart failure and cardiogenic this is not the shock because the patient's not hypotensive, but you can still use it on those hypotensive patients. And one more. There's 2 more questions. We're just going through all of them to make sure we remember. 55-year-old male with a past medical history of hypertension and alcohol abuse is triaged to your emergency department for 1 day of multiple episodes of bloody vomitus. Patient denies any abdominal pain, fever, chills, chest pain, syncope, or change in stools. Patient denies any history of similar symptoms in the past. He reports poor compliance with his hypertension medications and drinks 1.5 liters of vodka per day. Upon initial exam, he's pale appearing, but no respiratory distress. His vital signs are there: blood pressure 85/60, heart rate of 120, respiratory rate of 18, 98% on room air. Patient is initially given 1 liter of fluid with no change in blood pressure. What fluid should be administered next? Good. Great. So the red blood cells. So this one's just kind of going over our hemorrhagic shock. So hemorrhagic shock, biggest point is somebody that's losing blood needs blood. They don't need fluids, they need blood. And yep. And last one. So 35-year-old male with no past medical history presents via EMS after falling from a tree. He's in a seat collar and on a backboard. Vital signs are as follows: blood pressure of 85/50, heart rate of 55, respiratory rate of 18, pulse ox of 92% on room air. His airways patent. He has bilateral breath sounds. Peripheral pulses are bounding in all extremities. No open wounds or exsanguination. FAST is negative. Patient is alert and oriented, answering questions appropriately. He has numerous bruises and abrasions. He has complete loss of sensation and motor function below the level of T4. He was able to get a CT imaging that revealed compression fracture of T4 with spinal cord compression. No other internal injuries. After 1 liter of normal saline, the blood pressure remained 85/40. What should be done next to decrease his risk of secondary injury to the spinal cord? Good. Awesome job, everybody. So as we talked about last week with neurogenic shock. So in these patients, you want that map to be on the higher side from the other shock. So a map of 85 to 90. So we get that good perfusion to the less vital organs, such as the spinal cord, and assure that we're not getting any secondary injury. So a little bit higher blood pressure on those. So that was our last question. I just wanted to throw those other ones in there, ones that I thought kind of honed in on the points that we talked about this last month. And yeah, that's it. If anybody has any questions about anything the last 5 weeks, it's a lot, please let me know. Or wants to tell me anything, teach me anything, tell me a cool case.
Claudia, this was such a great lecture. I really appreciated all your time that you put into talking about this really interesting topic and shock in general. So thank you, Claudia. And
you're welcome.
Yeah, well done.
Thanks. I'll say too, I'm sad I'm going to miss you guys in Vietnam this year, but I'm doing a 2-year fellowship. So hopefully, if not in the spring next year, I'll be there.
Dr. Claudia has to come to Vietnam, otherwise she's not allowed to graduate. So we're going to hold her to it.
Yeah, I can handle that.
Especially now that she's got all these friends there. So
yeah.
Thanks, Claudia.
Thank you. Thank you very much.
You're welcome. Yeah, please feel free anytime if something comes up. If you guys have an interesting case with regards to one of these topics, even past this month, I would love to hear about it or hear, how your approach anything. It's really fascinating to me to see how you guys practice medicine, and I'd love to learn from you guys. So if you have a case that pertains to this and you're like, hey, I want to do that, I would love to hear about it.
You can always put it on the WhatsApp group too, everyone. If you have a case that you want to talk about with the rest of us or just share with us, please feel free to include it on the WhatsApp group that you're all a member of. So Thank you, Dr. Claudia.
Yeah.
Great job.
Okay. Bye, guys. Thank you so much. Okay.
Good night, everybody.